For peripheral arterial disease, we want to have a quick intro by starting at how we approach the patient in the clinic. And so this video will discuss management. In other words, we'll discuss the practicalities on how to approach the patient. There are very few notes. This is just an intro to highlight some of the important things. We will not be discussing anatomy, and we will not be discussing the pathogenesis or pathophysiology and etiologies in details. Peripheral arterial disease, they're strongly linked to smoking. You have to counsel your patient on quitting smoking. You have to look for comorbidities, all the cardiovascular disease risk factors, but look for 3. Smoking, we said, is number 1, and then look for another 3, and those you'll find that are very similar to the the modifiable causes of mortality, the top list. So you have hypertension, diabetes, and obesity, and I may want to add inactivity as a separate entity. As with any patient who has established cardiovascular disease, all patients should be taking a statin. Atorvastatin, which is a high intensity statin at 80 milligram, is currently the recommended dose. Back in 2010, the National Institute of Care Excellence, UK, published guidance suggesting that clopidogrel should be used first line in patients with peripheral arterial disease in preference to aspirin. Exercise training has been shown to have significant benefits. Now, according to also the National Institute of Care Excellence, they recommend supervised exercise programs. Do not tell the patient to just go to the gym. You want all patients with peripheral arterial diseases to have this chance to improve their habitus before trying other intervention, if applicable, meaning if amenable and possible without side effects. And severe peripheral artery disease, those that pose critical limb ischemia, that's what we mean by plausibility of exercise. That's what we are afraid of. We're afraid of limb ischemia. Those cases you want to go ahead and treat with stenting, bypass surgery, or angioplasty. So stenting and angioplasty, they can be done interventionally. Bypass surgery needs to have a full-blown surgery. Amputations should be reserved for patients with critical limb ischemia. Look how we are escalating hypertension, quitting smoking. Then they start having some peripheral artery disease, and we're going to do a graded supervised exercise program and monitor them and hope for the best. And then if they progress, then we need to do an angioplasty, stenting, or even go for a bypass surgery. And then there is the amputation. Amputation should be reserved for patients with critical limb ischemia who are not suitable for other interventions such as angioplasty or bypass surgery. Now, there are drugs, and drugs licensed for use in peripheral arterial disease include interesting drug called naftidrafurel. And I believe the trade name should be easier to memorize. 1 second, I'll look at my note. So it's called Praxaline. But anyways, the scientific name is naftidrafurel. And naftidrafurel oxalate is the full name. It's a vasodilator, sometimes used for patients with poor quality of life. And the way it works is it vasodilates through the inhibition of the 5-hydroxytryptamine type 2 receptor. So it's an antagonist of this serotonin receptor. And it's used for peripheral arterial disease as the main indication for this specific drug. The other drug that is available and licensed for use is also, interesting name, cilostazol. Cilostazol. That's Cilostazol. Now, cilostazol is a phosphodiesterase 3 inhibitor, which with both antiplatelets and vasodilator effects. This one is licensed, but it is not recommended in the guideline from the National Institute of Care Excellence. Further notes on the treatment. If you had to choose a drug, choose naftidrafurel. And if the patient has clinical features of intermittent claudication secondary to peripheral artery vascular disease, that is the indication. Intermittent claudication, it improves the quality of life. It improves the claudications, okay? If you think about other modalities, it's interesting how this is a serotonin receptor. If you give an alpha-1 blocker, for example, duxasthosine. It actually, things like that don't help for some reason, even though they do cause smooth muscle relaxation. They don't have a role in peripheral vascular disease. They're not licensed. Beta agonists are not used, and beta blockers are because they will cause the opposite. And beta blockers will not work because they're going to cause an unopposed alpha stimulation, which will cause vasoconstriction rather than dilation. And obviously, dopamine antagonists are not used. Those will have central effects, and those are used to treat psychosis, nausea, and vomiting. They have no role here.